Oh, yeah, we're still in Greece. But instead of living the myth, we're going to recreate the myth from the safety of the workshop. That stony liver, remember, represents hepatic cirrhosis due to chronic liver cell injury. In this sketch, we're going to assess the severity of cirrhosis and look at some complications and management options. Before we begin, let's recap the clinical presentation of cirrhosis with our sample assessment from part 1. Bellerophon is a 55-year-old male presenting with poor appetite and nausea for the past month. He also complains of a swollen belly and puffy feet that have been bothering him for several months. On questioning, he admits to drinking a six-pack of beer almost every night for the past 20 years. Physical exam is significant for bilateral gynecomastia, spider angiomas on the chest, visibly dilated periumbilical veins, and a palpable spleen tip. Labs are significant for an AST of 195, ALT of 101, elevated GGT, and a platelet count of 80. Given his history and significant alcohol use, his symptoms and signs are concerning for cirrhosis secondary to alcoholic liver disease. On with the plan. The first step is to assess the severity of liver disease. One way we do this is by calculating the patient's MELD sodium score. The MELD sodium score uses values for serum bilirubin, creatinine, sodium, and INR to predict 3-month survival in patients with cirrhosis. An increasing score is associated with increased mortality risk. To emphasize that this is a score measuring mortality risk, we've given this bronze melder a skull mask. And to remind you that it's 3-month survival specifically, we put 3 moons on the wall above. It's primarily used to prioritize patients on the waitlist for deceased donor liver transplantation. In 2016, serum sodium was added to the MELD score. Hyponatremia can occur in the setting of cirrhosis and is an independent predictor of mortality. Hyponatremia is related to increased water retention in the setting of increased ADH secretion. Check out our last video for the full mechanism underlying the hyponatremia seen in cirrhosis. There are a few conditions associated with chronic liver disease not accounted for in the MELD score that may affect survival. These are known as standard MELD exceptions. Patients who meet criteria for one of the standard MELD exceptions may be eligible for an upgrade in their MELD score. The exceptions include hepatocellular carcinoma, hepatopulmonary syndrome, portopulmonary hypertension, and a few other conditions. The MELD score will come up again at the end of this video when we discuss indications for liver transplantation. Another method we use to assess liver disease severity is the Child-Pugh classification system, which uses values for serum albumin, bilirubin, and prothrombin time, as well as the presence of ascites or hepatic encephalopathy to stratify patients into 3 classes of cirrhosis. To remind you that the Child-Pugh classification system correlates with survival, we've incorporated our mortality skull symbol into that last sculpture there. Patients in Child-Pugh Class A have well-compensated cirrhosis. Those with Child-Pugh Class B cirrhosis have significant functional compromise, and those in Child-Pugh Class C have decompensated cirrhosis. 1-year survival rates for patients in Class A, B, and C are approximately 100, 80, and 45% respectively. Once you've assessed the severity of liver disease, it's time to treat the underlying cause. All patients with cirrhosis, especially those with alcoholic liver disease, should refrain from alcohol use, as highlighted by the falling drinking horn. We also included a falling viral lantern to remind you that patients with hepatitis B or C should receive antiviral treatment. Recall that non-alcoholic liver disease typically develops in patients with at least one component of the metabolic syndrome, such as hypertension, diabetes, hyperlipidemia, and obesity. Patients with NAFLD should be treated with lifestyle modification, diabetes control, and lipid control. Weight loss specifically has been shown to improve LFTs, liver histology, insulin levels, and quality of life. In addition to treating the underlying cause of liver disease, you should also take measures to prevent further insults to the liver. Vaccination against hepatitis A and B for those who are not already immune can help prevent further liver damage. Patients should also avoid medications, supplements, and other substances that are associated with liver injury. Because patients have impaired hepatic metabolism, certain medications should have their dose adjusted or be avoided entirely. All right, that about does it for the general management of cirrhosis. But what about the complications of cirrhosis? Despite all of these measures, patients with cirrhosis can indeed still develop complications, and it's crucial that you know how to identify and manage them. The first one we'll talk about is esophageal varices. As mentioned in the prior sketch, this is a consequence of portal hypertension and can lead to life-threatening bleeding, presenting with hematemesis and or melena. Most patients with cirrhosis should undergo diagnostic upper endoscopy to screen for esophageal varices, determine the risk of variceal hemorrhage, and indicate strategies for primary prevention of variceal hemorrhage. Patients with medium or large varices are at risk of hemorrhage and should be given prophylaxis to decrease the risk of bleeding. Patients with small varices with high risk features or later stage disease may also get treated. Non selective beta blockers such as propranolol and nadolol are used to decrease progression and reduce the risk of variceal hemorrhage. They're thought to act by decreasing adrenergic beta activation in mesenteric arterioles, which results in unopposed alpha mediated vasoconstriction and decreased portal venous flow. Endoscopic variceal ligation is an alternate therapy for primary prophylaxis of variceal hemorrhage. It's performed on patients with medium or large varices who are intolerant of or have contraindications to beta blockers. And what about acute management of variceal hemorrhage? Check out our surgery course for a full discussion. Next, let's talk about ascites, which occurs in patients with portal hypertension. However, cirrhosis is not the only cause of ascites. And that's why we have a dedicated ascites DDX video coming up next. Recall from our last video that ascites results from portal hypertension as well as decreased oncotic pressure from impaired albumin synthesis. It presents with abdominal distension, shifting dullness to percussion, and a positive fluid wave. Patients suspected of having ascites based on history and physical examination should undergo abdominal ultrasound to confirm its presence. So we've brought in an ancient Greek ultrasound bullhorn. A paracentesis should be performed for newly diagnosed ascites, or for patients with pre existing ascites who are hospitalized, or, thirdly, for patients with ascites whose condition is worsening. If cirrhosis is the cause, expect to see clear yellow fluid, unless there's an underlying infection, but more on that in a minute. Peritoneal fluid is then sent for analysis. The serum to ascites albumin gradient, or SAG, is the serum albumin concentration minus the peritoneal fluid albumin concentration, which is why the pot is a sanguinous red on one side and an acidic yellow on the other. Expect the SAG to be greater than or equal to 1.1 grams per deciliter, indicating the presence of portal hypertension. Also expect the total protein in the peritoneal fluid to be low. Don't worry, We have a bunch more info on peritoneal fluid analysis in our upcoming ascites DDX video. The treatment of ascites aims at decreasing fluid overload. It involves restriction of dietary sodium, which limits the kidney's ability to hold on to salt and water. Diuretics are also administered. Combination therapy with spironolactone and furosemide is the standard therapy for ascites. So, on this leaky diuretic pot here, we've painted a spiral for spironolactone and a loop for the loop diuretic furosemide. For patients with tense ascites, more rapid removal of fluid can be performed without hemodynamic compromise with a large volume paracentesis of 4 to 5 liters. So, we've added a tap on the side here to relieve the pressure. Let's move on to a potential complication of ascites. Yes, a complication of a complication. Spontaneous bacterial peritonitis, SBP, refers to bacterial infection of acidic fluid in the absence of an intra-abdominal, surgically treatable source. It generally occurs in patients with ascites secondary to cirrhosis. Bacterial translocation is the presumed mechanism for development of SBP, with gut flora traversing the intestine into mesenteric lymph nodes, leading to bacteremia and seeding of the acidic fluid. As a result, the most common organism is the gut bacterium E. coli. Klebsiella pneumoniae is another common pathogen. These two are depicted by Hercoli here and as Klebsiella club. Streptococcal species and other gram-positive cocci are other common pathogens associated with SBP, possibly due to the altered microbiome of patients with cirrhosis. SBP almost always develops in patients with large volume, clinically obvious ascites in the setting of advanced cirrhosis. Also, the higher the MELD score, the higher the risk of SBP. Now, it's extremely important to recognize spontaneous bacterial peritonitis early. These patients rapidly progress to shock, followed by multisystem organ failure. Subtle changes in mental status are one of the most common signs of SBP, and may only be noticeable by someone who knows the patient well, like a spouse. Patients may also present with frank delirium, confusion, and slowed cognition. Abdominal pain may also be present, but it's often less prominent due to the presence of ascites. The pain is usually diffuse and constant. Of note, this pain is different than the pain felt from the stretching of the abdomen in the setting of tense ascites. Diarrhea is also common in patients with SBP, likely due to an alteration in gut flora. Patients typically present with fever. It's important to appreciate that patients with advanced cirrhosis are usually mildly hypothermic. So, a temperature of 37.8 degrees Celsius, or 100 degrees Fahrenheit, or greater must be taken seriously. And that septic pot is there to remind you that patients may also present with hypothermia or hypotension. These are signs of advanced infection and indicate a poor likelihood of survival. On physical exam, patients can present with diffuse abdominal tenderness. These patients do not develop a rigid abdomen, although rebound tenderness may be present in advanced cases. On labs, objective signs of infection may be present, including leukocytosis and metabolic acidosis. At Sketchy, we always include a flock of white birds to represent elevated white blood cell count. For making the diagnosis of SBP, paracentesis is the test of choice, depicted by the sample of fluid leaking from the pot there. The main diagnostic criteria are a positive ascites fluid culture and a neutrophil count greater than 250 per microliter. These are depicted here by the culture dish on the floor, as well as the first responders carrying the stretcher. At Sketchy, we think of neutrophils as the first responders of the immune system. Paracentesis should be done before antibiotic therapy is initiated, by the way, as early antibiotics can cause a negative ascites culture. Alright, before moving on, a quick aside. Spontaneous bacterial peritonitis must be distinguished from secondary bacterial peritonitis. Instead of being spontaneous, secondary bacterial peritonitis is, well, secondary to something. That something is a surgically treatable source of infection, such as a GI tract perforation or an intra-abdominal abscess. I know, you're thinking, a perf? I know a surgical abdomen when I see one. The thing is, ascites separates the visceral and parietal peritoneal surfaces and prevents development of a rigid abdomen, even with organ perforation. Other signs that point toward a secondary cause of peritonitis include a polymicrobial culture on gram stain, which indicates a perforation, a poor response to antibiotics, especially if there's an increase in ascites PMN count on follow-up paracentesis, And there's also a few extra acidic fluid labs we can look at, listed in the text on the screen. If signs point toward a secondary cause of infection, get plain and upright abdominal films, as well as a CT abdomen to look for that surgically correctable etiology. Alright, how about a sample assessment statement just for good measure? Bellerophon is a 55-year-old male with a history of cirrhosis secondary to alcoholic liver disease, admitted to the emergency department for abdominal pain. He describes the pain as diffuse and constant, and his wife reports that he's more confused than usual. He takes no medications and drinks a six-pack of beer daily. His temperature on admission was 101 degree Fahrenheit, with the physical exam remarkable for yellow discoloration of sclera, distended, non rigid, diffusely tender abdomen with shifting dullness and fluid wave present. Diagnostic paracentesis showed PMNs at 310 cells per milliliter with culture scent. Fever, abdominal pain, and ascites fluid analysis are concerning for spontaneous bacterial peritonitis. While awaiting the results of the fluid cultures, patients with suspected SBP should be started on empiric antibiotics. Empiric therapy usually includes a third generation cephalosporin, such as cefotaxime or ceftriaxone. Which is why Hercules is fighting a huge cephalopod on this pill bottle themed vase. Not only that, the cephalopod is wielding three axes. Think axe for ceftriaxone and cefotaxime. Patients at high risk of SBP, including those with a history of SBP or cirrhosis with GI bleeding, should be given antibiotic prophylaxis to prevent development of SBP. Regimens vary and can include trimethoprim sulfamethoxazole or fluoroquinolones. Alright, let's move on to hepatic encephalopathy, symbolized by this altered flapping Pegasus. Hepatic encephalopathy occurs because the cirrhotic liver becomes increasingly unable to perform its normal job of metabolizing ammonia and other toxins. We talked about the clinical manifestations and diagnosis of hepatic encephalopathy in the prior video, which include altered mental status, asterixis, other signs of neuromuscular impairment, and elevated serum ammonia. The initial management of acute hepatic encephalopathy in patients with cirrhosis involves two steps. The first step is identification and correction of the underlying cause. So let's draw in a Greek dude chiseling at the underlying base of the statue. Remember that the liver is unable to process toxic proteins in the blood. As such, a few of the common precipitants of hepatic encephalopathy involve increasing the amount of proteins and toxins heading to the brain. GI bleeding, for example, causes more protein to land in the GI tract, which is absorbed into the blood. Infection, including SBP and UTIs, are some of the most important causes of increased bacterial proteins and toxins entering the blood. Renal failure, too, decreases the body's ability to excrete ammonia and toxins. How about constipation? More time for gut bacteria to send proteins and toxins into the blood. States of hypoxia are also associated with hepatic encephalopathy. Hence the dead hypoxic head of Medusa up there. Not a good look. States of hypovolemia, caused by diuretics, vomiting, or excessive diarrhea, for example, can also precipitate hepatic encephalopathy. Low intravascular volume leads to a metabolic alkalosis with associated hypokalemia. And the brain doesn't like hypokalemia, not to mention low perfusion. Treatment includes volume resuscitation and repletion of potassium. Once you've addressed the underlying cause, the second step in the treatment of hepatic encephalopathy is initiation of measures to lower blood ammonia concentrations. Lactulose is the drug of choice for lowering ammonia concentrations. Lactulose is metabolized by gut bacteria into acidic metabolites. In the resulting acidic environment of the gut, potentially toxic ammonia is converted to ammonium and excreted by the body. For patients who have not improved within 48 hours or who cannot take lactulose, rifaximin is another treatment option. It reduces ammonia production by eliminating ammonia-producing colonic bacteria. Together, treatment of the underlying cause and reduction of serum ammonia concentrations will result in improvement in the patient's mental status. Alright, that's it for hepatic encephalopathy. On to portal vein thrombosis. Portal vein thrombosis involves the blockage or narrowing of the portal vein by a blood clot. It's a relatively common complication of cirrhosis and thought to be related to unbalanced hemostasis and slowing of portal flow due to portal hypertension. Portal vein thrombosis can be acute or chronic. The clinical presentation of portal vein thrombosis is variable. While it's often clinically silent, acute thrombosis may present with symptoms that include abdominal pain, distension, nausea, and fever. So called septic portal vein thrombosis can even occur, presenting with spiking fevers, chills, and a painful liver. If the mesenteric veins become involved, mesenteric ischemia or infarction can occur, manifesting as abdominal pain, ileus, hematochezia, peritoneal signs, or lactic acidosis. Check out our Dia de los Muertos sketches over in the GI unit for more ischemic fun. In contrast, variceal bleeding is the most common presenting symptom of chronic portal vein thrombosis. That's because thrombosis in the portal system only further increases portal hypertension, sending that pressure instead to the portal cable shunts, which over time turn to varices at risk of bleeding. So we've brought in a few extra variceal monsters bleeding at the mouth. As we covered in the last sketch, recall that variceal bleeding can present as hematemesis, hematochezia, or melena. Patients with chronic portal vein thrombosis may also present with the typical signs of portal hypertension, such as splenomegaly and ascites. Though it's important to remember that portal vein thrombosis is not necessarily the cause of deterioration and may be superimposed on progressively worsening cirrhosis. Portal vein thrombosis can be diagnosed with a Doppler ultrasound, though it's often diagnosed incidentally on ultrasound or CT imaging being performed for a different reason, such as diagnosis or monitoring of hepatocellular carcinoma. Patients with chronic portal vein thrombosis should be screened for esophageal varices. Varices, if found, are usually treated in the standard manner. The management of portal vein thrombosis, PVT, is exactly what you'd expect: anticoagulation. Start with low molecular weight heparin to achieve rapid anticoagulation, and then bridge to an oral agent when the patient's condition has stabilized. Because these patients are at risk of variceal bleeding, the decision to anticoagulate must be made on a case by case basis. Anticoagulation is typically reserved for patients at risk of rethrombosis. Varices must be properly managed and treated, either with beta blockers or endoscopic procedure, before anticoagulation is started. All right, on to our next complication of advanced cirrhosis: hepatorenal syndrome. As described in the previous sketch, portal hypertension causes splanchnic pooling of blood. Not only that, the cirrhotic liver has a hard time metabolizing all the toxins entering the blood through the GI tract, including bacterial toxins. This causes increased nitric oxide production by vascular endothelial cells. Systemic vasodilation follows, especially of the splanchnic vessels, which we symbolized with these dilated abdominal snakes here. With all that blood pooling in the splanchnic circulation, the kidneys become hypoperfused, and creatinine rises. The onset of hepatorenal syndrome is usually insidious, though it can be precipitated by acute insults, such as spontaneous bacterial peritonitis and upper GI bleeding. With all that pooling and vasodilation, how about we get that pressure back up? For patients who are unlikely to have a quick recovery, there are a few therapies used to improve renal perfusion. This buff dude grabbing the snake, constricting it, if you will, represents vasoconstrictors, which can help constrict the splanchnic vasculature and raise the mean arterial pressure. Critically ill patients may be given norepinephrine, while more stable patients can be given midodrine plus octreotide. Midodrine is a systemic vasoconstrictor, while octreotide inhibits endogenous vasodilator release. Therapy is usually continued for 2 weeks. In combination with pressors, albumin is administered to increase oncotic pressure, thereby increasing the intravascular volume for better kidney perfusion. Albumin is administered for at least 2 days. As with most of the complications we mentioned, the ideal therapy for hepatorenal syndrome is improvement of liver function from treatment of the primary liver disease. If this is not possible, a TIPS procedure or liver transplantation may be the best option. Moving on from the kidneys to the lungs. Patients with long-standing cirrhosis and portal hypertension can develop hepatopulmonary syndrome, or HPS. The mechanism is complex, but involves abnormal vasodilation of the pulmonary vasculature. The result is intrapulmonary shunting, leading to VQ mismatch and hypoxemia. Patients present with dyspnea. The definitive therapy is liver transplant, typically for patients with an arterial partial pressure of oxygen less than 60 millimeters of mercury. And finally, the last complication of cirrhosis to discuss: hepatic hydrothorax. Ascites is sometimes associated with the transudative pleural effusion, thought to occur due to small defects in the diaphragm. These defects permit peritoneal fluid to pass into the pleural space. The passage of fluid is promoted by the negative intrathoracic pressure generated during inspiration. The effusion typically manifests in the right hemithorax, but it can be left sided or bilateral. Hepatic hydrothorax is suspected in a patient with cirrhosis and a pleural effusion, usually greater than 500 milliliters, who has no other reason to have a pleural effusion. In other words, there's no known cardiac, pulmonary, or pleural disease. Patients with hepatic hydrothorax generally present with typical pleural effusion symptoms that include dyspnea, non-productive cough, pleuritic chest pain, and hypoxemia. The diagnosis is confirmed with diagnostic thoracentesis, which will show evidence of a transudate. Check out our pleural effusion DDX sketch for all the sopping wet details. Treatment of hepatic hydrothorax is similar to the treatment of ascites: salt restriction, diuretics, and abstinence from alcohol. Definitive therapy is, of course, liver transplantation. Speaking of, over next to this liver plant, let's talk about transplant. To become eligible for a liver transplant, it's not enough to simply have cirrhosis. Remember the MELD sodium score? As discussed earlier, it plays a vital role in the allocation of liver transplants. Patients with cirrhosis are typically candidates for liver transplantation once their MELD sodium score is greater than or equal to 15. The transplantation evaluation is typically started once a patient's MELD sodium score is greater than 10. This permits the patient to meet the transplantation team prior to the development of end-stage liver disease and ensure adequate time for the patient to complete the pre-transplantation evaluation. Patients may also qualify for liver transplantation if they have a complication or condition that qualifies for one of the standard MELD exceptions that we mentioned earlier in the video. Lastly, patients with conditions that are related to their liver disease that don't qualify for the standard MELD exception points can be considered for liver transplantation if their medical providers believe that the MELD sodium score does not adequately reflect the true severity of their disease. Some of these complications include refractory ascites, refractory hepatic encephalopathy, and refractory variceal hemorrhage. All right, sum up time. We assess the severity of disease with the MELD sodium score. It uses bilirubin, creatinine, sodium, and INR to predict 3-month survival. It's primarily used to prioritize patients on the waitlist for liver transplantation. There are also a few conditions dubbed standard MELD exceptions which can bump up the MELD score. The Child-Pugh classification is used to stratify patients into 3 classes of cirrhosis, each correlating with a range of 1 and 2 year survival times. Treat cirrhosis by treating the underlying cause. That means, when applicable, abstinence from alcohol, antivirals for Hep B and Hep C, and weight loss. In all patients, it's important to vaccinate against Hep A and Hep B, avoid hepatotoxic meds, and remember that other meds may need to be adjusted. Esophageal varices are a complication of portal hypertension that can lead to life-threatening bleeding. Most patients with cirrhosis will get screening with upper endoscopy. Patients with medium and large varices will be given primary prophylaxis to decrease bleeding risk. This includes beta blockers and endoscopic ligation. Patients with new ascites should receive an ultrasound to confirm. A paracentesis should be performed for newly diagnosed ascites, or for patients with pre-existing ascites who are hospitalized, or, thirdly, for patients with ascites who are deteriorating clinically. On paracentesis, expect clear yellow fluid and a SAG greater than or equal to 1.1. Treat ascites with sodium restriction, diuretics such as spironolactone and furosemide, and, if tense ascites, large volume paracentesis. SBP is a bacterial infection of ascites fluid not caused by a surgically treatable source. Typically, it's from gut bacteria such as E. coli and Klebsiella. It can present with diffuse abdominal pain, altered mental status, and diarrhea. These patients typically present with fever, and it can progress to septic shock, so watch out. Get a paracentesis. The diagnostic criteria include a positive ascites fluid culture and a PMN count over 250. Differentiate it from secondary peritonitis, which can be caused by bowel perf or intra-abdominal abscess. While awaiting cultures, empiric therapy usually includes a third-generation cephalosporin. Prophylactic antibiotics should be given to patients with a history of SBP or cirrhosis with GI bleeding. Hepatic encephalopathy is treated by treating the underlying cause, and there are numerous. Lactulose and rifaximin are used to reduce the ammonia being generated by gut bacteria. Portal vein thrombosis presents acutely with abdominal pain, distension, nausea, and fever. It can even be septic with a painful liver and spiking fever and chills. Mesenteric ischemia can complicate the situation as well. Chronic portal vein thrombosis presents with variceal bleeding and other signs of portal hypertension. Portal vein thrombosis can be seen with Doppler ultrasound or other imaging. Patients should be screened for varices as well. If varices are treated appropriately, some patients will be put on anticoagulation. Hepatorenal syndrome is usually insidious in onset, but can be precipitated by an acute stressor, such as a GI bleed or SBP. It's treated with vasoconstrictors and albumin infusion to get blood back to those kidneys. Hepatopulmonary syndrome presents as a triad of liver disease, hypoxemia, and intrapulmonary shunting caused by pulmonary vasodilation. Treat severe cases with O2 and eventually liver transplant. Hepatic hydrothorax is suspected in patients with cirrhosis and a pleural effusion with no other obvious etiology. They present with dyspnea, cough, chest pain, and hypoxemia. Thoracentesis will show a transudate. And finally, liver transplant is indicated when a patient has a MELD score greater than or equal to 15, or they may qualify with certain MELD exceptions. All right, that's it. Next up, the bathhouse, where we'll jump into that ascites fluid, wait around a little, and get all saggy. It's more fun than it sounds.